But, so respiratory viruses and some bacteria are transmitted via certain modes, primarily inhalation of fine particle aerosols that range from very large particles that deposit primarily in the nose and mouth to those that enter the chest that are somewhat smaller. And finally, very small aerosol particles that can penetrate deep into the lung. And there was a lot of misunderstanding early in the pandemic. Traditionally, medical people have thought about only these very small aerosols and misunderstood how they behave. Spray and touch are other modes of transmission. Primarily, probably touch is important. The spray of ballistic droplets is probably a relatively minor mode of transmission. But one of the things that's really important to understand is that the cloud of fine aerosol particles is most concentrated close to the source, and not only something that happens far away on rare occasions, but rather dominates what's happening close to the source. This has been a misunderstanding again, with often thinking that anything that happens close to the source must be spray driven. But we now understand that, in fact, it's primarily aerosol inhalation that's happening close to the source, or touch. And the other thing that's really important to understand about transmission of these infections, influenza and SARS-CoV-2, is that only a small fraction of people are symptomatic. And this is from a paper almost 10 years ago in the UK, looking at people without influenza vaccine in a medical practice and showing that indeed the vast majority of people who become infected have no evidence of symptoms, but they develop antibodies showing that they've been infected. And it's only the tip of the iceberg who are actually medically attended cases. And yet all of these people are potentially contagious. And this has been a huge problem during COVID, because we understand now that asymptomatic people can be contagious. This should have been evident very early in the pandemic, because back in January from Wuhan, there was a family that traveled and had symptomatic COVID among the adults, but a 10-year-old who was asymptomatic had ground glass opacities in the lung and was cruelly infected. And those ground glass capacities suggest that he had infection where aerosols are generated from the lung. So just focusing on the acute infections is not going to be effective because we don't know who all the people are who might be contagious. Source control must be directed towards everyone in the workplace, healthcare in particular. So we've been studying in my lab for many years how people generate aerosols of infectious agents. And we study them with this by asking people with influenza and COVID to come sit in a booth where we sample the air around their head as they breathe, cough spontaneously, talk, sing, yell, and so forth. In our flu studies, we just had people cough spontaneously and recite the alphabet a few times. And yet we found that even with no coughing, people were shedding significant amounts of viral RNA into the air, and that we were able to culture virus from these people. And you see in half an hour, these people were shedding up to hundreds of thousands of viral particles into the air. We've also looked in these studies at masks and respirators as source control. And in the earliest study published 10 years ago, we showed that putting a surgical mask on people with influenza reduced the amount of virus that they were shedding into the larger particles that float in the air. It pretty much eliminated them except for a few cases. For the finer particles, it cut them down about in half. But the other thing to notice here is that even among the people with no masks, that the amount of virus in fine particle aerosols that float in the air and can penetrate deep in the lung are more than those in the coarser particles that will not travel very far. NIOSH's CDC has done some nice studies looking at the effect of masks using this laboratory system with mannequins. And they have shown that ear loop surgical masks like these have some impact, and that as you tighten up the fit on these masks, they work better. And that as you have more people in the environment masks, they work better as well. If you just put the mask on the source and it's a surgical mask or a cloth mask over a surgical mask or a knotted mask, as you get the fit better, they get better. If you put a mask on the recipient, it also has some effect. And if everybody is masked, it does even better. And this is now using, even in this case, medical masks and knotted and cloth masks. It's not using N95s. We then extended this work to look at N95s. We had, during the pandemic, here as a timeline, studied cloth masks and surgical masks and KN95s. And later, during Omicron, we studied N95s. Again, with this same apparatus, having people give us a sample with their mask on and then without a mask. And what we see is shown here. This is going to the left is better. This is here how much they were shedding with no mask. This is here 10% still getting through, and here is 1% getting through. And you can see that N95s vastly outperformed all other masks. And interestingly, cloth masks, when people made their own cloth masks and they wrap well around their face and fit fairly tightly, actually outperformed surgical masks and KN95s, and quite statistically significantly. But if you looked at the percent improvement of N95s over the others, N95s had a 93% improvement over what was accomplished by surgical masks and a 94% improvement over KN95s, albeit our KN95s were very stiff and didn't fit very many people well. So when you think about what to do, you have to have a risk assessment and control banding as critical tools to decide where you should put your controls. And there are a number of factors that have to be taken into account. The prevalence of respiratory infections in the community, how active is COVID, how active is flu, how pathogenic are the infections that are going around, how much morbidity and mortality is there, can source controls be implemented? It's very rare that cases are distinct and symptomatic enough to be able to use only very directed source control. Can pathway controls be implemented? Can receptor controls be implemented? And what is the availability of medical countermeasures? Pathway controls have to be the first level of things, because ventilation, filtration, air disinfection are things that can be operational all the time before you know you have a problem. They're passive and always active, and they can always be upgraded with increasing risk. Source and receptor controls both require behavioral interventions, and are difficult to implement sometimes. And source and receptor controls can be added as the risk increases.